Hi, everybody, and welcome to Chapter 12, where we're going to talk about schizophrenia. This is a very prevalent disorder, probably maybe way more prevalent than you even imagined. It's about 1 in 100 people right now, equal between men and women, but a disorder that you probably wouldn't know is around and is prevalent as it really is. When we're talking about schizophrenia, we have to first talk about psychosis, because this is really the hallmark of schizophrenia. It's really listed and defined as a loss of contact with reality. So here we might be talking about hallucinations, which are these false sensory perceptions. You can have auditory hallucinations, which are the most common, which is hearing things when there's nothing there. It's hearing voices in your head. It could be gustatory. It could be that you taste something in your mouth. It could be visual hallucinations where you see things that aren't there. Somatosensory, where you feel things touching your skin when nothing, in fact, is touching your skin. Even olfactory hallucinations, when you smell something and there's no origin for that smell. But again, the most common is going to be auditory hallucinations. There's also delusions as part of psychosis, which are these falsely held beliefs that aren't based in any sort of reality. And just responding to the environment in a disturbed, non-functional way. Okay, sometimes psychosis can be induced by substances, amphetamines. We've sometimes seen brain injury, but a lot of the times if we're talking about true psychosis, we're talking about it in terms of being a symptom of schizophrenia. Now, when we talk about true diagnoses, we're talking about the DSM-5, of course. This is the most recent version of the DSM, the Diagnostic and Statistical Manual of Mental Disorders. The last version, 5, came out in 2013, so we should be having a new version coming out soon. For a true diagnosis of schizophrenia, we have to see these symptoms of psychosis continue for at least 6 months or more. So it's very important we see some consistency there. And again, like with all disorders, but especially schizophrenia, we want to see this deterioration during the time of these consistent 6 months of symptoms, where work, social relationships, and their ability to take care of themselves is truly hindered. Okay, it's that dysfunctional part of the 3 big Ds that we can't discount. Again, 1 in 100, 2.5 million Americans, and it is one of the disorders that is diagnosed worldwide in every country in the world. Okay? Lots of financial and emotional cost associated. Many people who had started out maybe with adequate jobs, actually what we call the downward drift theory says that because of their schizophrenia and their psychosis, which interferes with their ability to hold a job, that a lot of people who were once doing quite well for themselves, once they had their first psychotic break, might find that they were kind of falling down in terms of their economic status because they weren't able to hold a job. In fact, here is a kind of graphic where that shows that 1.9% of people with schizophrenia make below $20,000. And again, this isn't across the board where they were always at this low of an income level. Sometimes it was much higher, but because of the interference with work, it really kind of moved them into the poverty level. This is important. We often talk about this in my class. When we hold this in a class-to-class, face-to-face situation, is that we have to remember that the age of onset between men and women can be very different. And what I also want to be clear about is that it's such, for the most part anyway, such a late onset for most people. 23 for men is the average onset of psychosis, compared with 27 for women. Regardless of what you're talking about, 23 or 27, these are a late onset for an average age of onset for any disorder. When we're talking about anxiety disorders or depressive disorders, excuse me, we're talking about usually could be childhood, early or late adolescence, but having this kind of early to, kind of mid-adulthood there is pretty late. So everything can be going on fine and you aren't experiencing any real significant symptoms. And then you might have your first psychotic break as late as 23 or 27. As far as marital status, it's broken up by, 3% divorced, 2% single people, 1% married. And a lot of that has to do with the relationships that are being hindered because of the symptoms. When we're talking about the symptoms, we can actually group them into 3 categories: positive symptoms, negative symptoms, and what we call psychomotor symptoms. So let's take these groups of symptoms one by one and take a look at them more specifically. So right here. Positive symptoms are what we call pathological excesses. And I know that sounds kind of strange, but think about it not emotionally, like positive is good and negative is bad necessarily, but think more like a mathematician, where positive symptoms mean the addition of kind of bizarre kind of symptoms. You know, these are the kind of symptoms, for the lack of a better way to explain it, that you know it when you see it because they are so different from the typical behavior you see in people. These delusions, again, these faulty held beliefs, people who talk about, you know, they're Superman or they're God, or they believe that, you know, aliens have implanted, you know, a tracking device in their brain or something, and they're very adamant about it. Not just a belief, but they very, very strongly live by this fault interpretation of reality. And they talk about it on a regular basis, and it just seems strange. Those are kind of the positive symptoms we're talking about. Disorganized thinking and speech. Again, their speech just doesn't make a lot of sense. We call it loose associations. Sometimes it's called a word salad, where if you took everything somebody was about to say and you kind of shook it up in a salad and you tossed it in the air, and however it came down was how the person would say those words. That's kind of what loose association. It just doesn't make a whole lot of sense. Or sometimes you might have individual sentences make sense, but the sentences don't really associate with each other. Derailments, meaning they just kind of start in one direction and go off in another, and, you know, go off on this tangent that doesn't make any sense. What we call neologisms are these kind of made up words where they just make up words out of nowhere, and you have to wonder, is that a real word? I've never heard of that before. Sometimes perseveration. Sometimes we see this in kids who have autism, especially who are really low on the spectrum scale. They might perseverate and say certain words over and over again, or repeat certain jingles they heard on a commercial maybe over and over and over again. There's something else called clang, where they say things that rhyme. You'll see on the PowerPoint there where it says, well, how, so well, it's to tell. So hot, you know, it runs on a cot. So it doesn't make a whole lot of sense, but what they say does rhyme, which is kind of interesting to listen to. Some other positive symptoms are heightened perception, meaning they're kind of flooded by the senses that are around them, whether they're visual or they're auditory. And it's really difficult for them to differentiate one sound from another. So a lot of people talking in the same vicinity will be very disturbing. Bright lights will be very difficult to tolerate sometimes, and, you know, they might run out of the room because it's just too much to handle. Hallucinations, again, are very common to psychosis. These are those most commonly auditory, but again, we have seen where they're tactile, somatic, visual, gustatory, olfactory. But a lot of times we hear where they'll say, oh, I hear voices in my head telling me to do bad things, or saying maybe terrible things about themselves. But they can sometimes be positive too. I do know of cases where some people will hear voices, auditory hallucinations, that tell them they're the smartest person in the room and they should be president. And I have a friend who actually is a psychologist who works with people with schizophrenia. And she had told me that she had some clients who heard positive voices, and those are the very reasons why they didn't want to go on their medication. It's because they actually liked to hear the positive voices and what they had to say about them. So it's kind of a way to look at it. And inappropriate affect is the other. So people will cry at birthday parties, or they'll laugh at funerals. They'll show emotions that seem really unsuited for the situation at hand. Now, those were positive symptoms. Moving on to negative symptoms, we also call those pathological deficits. But again, we're thinking about this mathematically. So it's not necessarily bad symptoms. They're all not good, but negative symptoms are the lack of appropriate symptoms, if you will. So positive symptoms are the addition of kind of those bizarre behaviors, or negative symptoms are the absence of kind of typical appropriate kind of symptoms, or appropriate behaviors, we should say. Poverty of speech, we call that alogia. So if there's very little speech, a person might be catatonic, where they say nothing at all, or they might have very little quantity or quality of speech, and a reduction in what normal people may say in a conversation. Blunted and flat affect is really another hallmark that we see in people with negative symptoms, where there's very little facial expression. And that's what we mean by affect, A-F-F-E-C-T, not affect, but affect. Blunted or flat affect means very little expression. When you're talking with someone and, they might smile at you or make a slight frown, or you see some sort of facial expression that goes along with what they're hearing or what they're saying. People who have blunt and flat affect, negative symptoms of schizophrenia, show very little of that. It's kind of almost scary, because there's this lack of avoidance of eye contact and this kind of expressionless face, much less emotion, monotonous voice, no intonations and highs and lows, and generally this lack of showing pleasure and enjoyment, anhedonia. We also see something called loss of volition, which is a loss of motivation or directedness to do things. So not having the energy to accomplish normal goals, like getting work done if they're taking classes, or getting projects done in their work life. This inability to have this motivation to even start doing anything. Social withdrawal is also very common, kind of withdrawing from any kind of social environment, and just wanting to kind of be alone. Breakdown in social skills that might have been there before the onset of some of these symptoms, and now they're showing a real lack of social skills and a total withdrawal of a social life in some instances. The third symptom is psychomotor. So we have positive symptoms, negative symptoms, and psychomotor symptoms. Think of motor as in movement. So these are psychomotor movements that are kind of strange looking. They're awkward. They might make strange facial movements, odd gestures, some kind of movements that look strange to the rest of us, but have some kind of quality to them that is either magical or that makes sense in terms of the voices that they may be hearing in their head, or maybe to the visual hallucination that they're seeing. You might see some strange kind of forms, catatonic forms that a person might take. They might be very rigid. They might show kind of strange posturing, or even excited movements that don't really go along with the situation that they're in. So what happens oftentimes with schizophrenics are we do see this late teens to mid 30s, but it's a late onset as far as disorders are concerned. And we see it running in 3 phases. What we call prodromal, which is the beginning of this deterioration, when a person first starts showing those mild symptoms, and this first kind of either positive, negative, or even psychomotor symptoms that are showing themselves, very different from what they had experiencing before, from typical behaviors. And then they move on to the active phase, which is when the symptoms are very apparent. They're experiencing them on an active basis, and people around them are able to notice that they're acting in a much different way. And then the last phase is called residual, and this is when they're returning back to those prodromal-like levels, those milder symptoms, and maybe even moving on to a phase of normalcy. And 1/4 of people actually do recover. 3/4 might show some residual problems, but I think there's this misconception that people with schizophrenia will always show psychotic behaviors, and that's just not true. I have a family member who actually has been diagnosed with schizophrenia. He had his first psychotic break when he was he was 17, so that was really considered early. And he has showed periods of normalcy where he can go to work and his family life is intact. He has a wonderful wife and who's very understanding, and even has children. So he's, leading what most would be considered a normal life, but he does go through active phases, but he also goes through phases where he shows normal, typical behaviors, which as a family we're very blessed to see. But it's not true of everybody. There are some people who, because of these particular characteristics, might have more of a difficult time. But people who make a fuller recovery, it tends to be because they had a later onset. So a later onset is good. There are people who have child onset schizophrenia, and they can show psychotic behavior as early as 4 or 5 years old. It can occur very early on in life. That is very rare. That's, if I remember my stats, I think it's 1 in 45,000. So it's very rare. But the later the onset, the actual better your prognosis is for having more periods of normalcy, if you will. If your psychotic break was kind of triggered by some sort of stressful or traumatic situation, that actually is a good sign in terms of you either fully recovering or having less chronic psychotic episodes. Again, later onset is always good. And receiving treatment early is always a good sign, no matter what disorder we're talking about. If it's treated earlier, that's always a good sign. Something else to really be mindful of is we don't use the same set of terminology that you may be used to. Before DSM-5, we had different sorts of schizophrenia. The one most people think about is paranoid schizophrenia. We had paranoid, undifferentiated, catatonic, delusional. There were many different types of schizophrenia before DSM-5. The problem is that was difficult because a lot of people didn't fit into a category. So they would all go under the category of what we'd call undifferentiated. That didn't always fit nicely. So what we had to do is come up with a different system. And the different system is what you have in front of you. It's schizophrenia 1 and schizophrenia 2. So we no longer use the terminology paranoid schizophrenic, catatonic schizophrenic, so on and so forth. We now say type 1 or type 2. Okay, so type 1 schizophrenia tends to be schizophrenics who are dominated by positive symptoms. What we had talked about earlier with the symptomology, those addition of kind of those bizarre kind of symptoms. Schizophrenia 2 tends to be dominated by the negative symptoms. And the causes of schizophrenia 1 and schizophrenia 2 look slightly different as well. But just remember, type 1 schizophrenia, more positive symptoms. Type 2 schizophrenia, more negative symptoms. Hopefully that will kind of help. Let's see. When we're talking about why it occurs as far as causes, looking at schizophrenia 1, schizophrenia 2, keep that in mind, will help with this explanation. We're looking at biological, psychological, and sociocultural theorists that have proposed different explanations, but by far the biological explanation has much, much more research behind it, much more research support. So I'm not really going to talk much about the psychological and sociocultural explanations because those don't have as much credence as the biological. Just know that if there is a biological predisposition, psychological and sociocultural factors can make the psychosis worse. But it's really unlikely that we're going to see somebody who doesn't have a biological predisposition where any sort of psychological or sociocultural trigger could cause them to be psychotic. Hopefully that makes sense. And that really is what the diathesis stress theory is all about, that you have to have it within your biology for the symptoms to show themselves. And you need a biological predisposition and then stressors or traumatic events that might make the symptoms show themselves. There are people who might have a biological predisposition to showing schizophrenia, but may never show the symptoms of it because there were no stressors that kind of brought it on. And that's where the psychology becomes important. But I could never stress you out enough as your professor to a point of making you psychotic. I couldn't do it if you didn't already have the biological predisposition within you. And we do have this strong genetic inheritance. It's not a one-on-one situation where if you have a parent who's schizophrenic, it automatically means that as the children of the parent that you would automatically be schizophrenic. It's not that closely related, but the likelihood does go up. Here, this might be kind of helpful to take a look at this. This is a graphic that shows your percentage of risk to showing symptoms of schizophrenia if somebody in your family has it. So if you have an identical twin, if you look down at the bottom, if you have an identical twin, there's a 48% higher likelihood that you might develop it as well. Offspring of two schizophrenic parents, now it's two, 46% higher likelihood than the rest of the population. A fraternal twin, 17. Offspring of one schizophrenic parent, 13%. A sibling, 9. One parent, 6. And then it goes down. So I do have a first cousin who is schizophrenic. So the likelihood of somebody, myself, or maybe one of my kids, likelihood going up, it's 1 to 2%, but it's really not that much. 1 to 2% more than the rest of the population. But there is a genetic factor there, and we should keep that in mind. And the reason for the genetics is because we see biological abnormalities that can be inherited, like biochemical abnormalities and abnormal brain structure. And we'll look at those one at a time. For biochemical abnormalities, we're looking at dopamine. There is a dopamine hypothesis that helps to explain why some people may generate these schizophrenic psychotic symptoms. If you have dopamine that fire too often, it could produce symptoms of schizophrenia, usually positive symptoms. And for people who have this schizophrenia 1, we tend to give antipsychotic medications that help lower the dopamine level. Now, what's kind of interesting, and I always found this fascinating, dopamine is really responsible for two very different disorders, others as well, but primarily in these two very different disorders. Of course, if you have too much, then you have, in some cases, you might develop the psychosis that we see in schizophrenia. If you don't have enough dopamine, you could develop what we call Parkinson's disease, which is a biological sort of disease that causes these kind of tremors, these motor-like responses in people. So people who are given L-DOPA for Parkinson's disease to heighten their firing of their dopamine might also experience some of the hallucinations or delusions that we see with schizophrenics. It doesn't mean they're developing schizophrenia, but because they have to increase their amount of dopamine, sometimes we will see some of that. And then also, on the flip side, people who are taking medication to lower their dopamine because they're schizophrenic may end up showing some Parkinsonian-like tremors. Kind of interesting. This dopamine hypothesis we tend to have seen in the 60s, because this is when we found out that Parkinson's disease had everything to do with dopamine level. And when you give people L-DOPA, it increases their dopamine levels, and that's when we thought, well, I wonder if that would work to, help lower the dopamine in people who have schizophrenia. But then we see these kind of counteractive side effects, which is kind of interesting. And also, because of the genetic inheritance, we also see brain abnormalities. Sometimes if you look at an MRI, you will see these they almost look like butterfly structures, but there's these brain cavities that are filled in cerebrospinal fluid, and these enlarged ventricles are oftentimes seen in people who have schizophrenia. And sometimes smaller temporal lobes. Remember, the temporal lobes are over by your ears. Frontal lobe is your forehead area. We tend to see small temporal and frontal lobes, smaller amounts of gray matter, and some abnormal blood flow to those brain regions as well. There is also know, it's a little bit controversial, but it's a viral kind of theory which says it's possible that women who have the flu, a viral infection, especially in their second trimester, may kind of contribute to their child developing schizophrenic symptoms. Because we find that schizophrenics are born in the winter months more than any other time of the year, statistically speaking. So there might be something to be said for this exposure to viruses that these people develop in utero before they're born, that their mothers have developed. And perhaps that might have something to do with the onset of symptoms for these people later in life. Maybe. It's a theory. So we have genetic factors, we have biological factors. There's also some, again, psychological cognitive perspectives that say that could be some psychological contributing factors as well. As far as sociocultural, we're mostly talking about how the family structure that the schizophrenic is a part of, how that might contribute. So some of that can be dealt with in a therapeutic way, having a family therapy kind of situation. For most of the 20th century, schizophrenics tend to be housed in asylums and institutions. We really don't have those kinds of things anymore. We tend to have much more outpatient than we do inpatient facilities. Inpatient facilities do exist, but not like we used to. We used to sequester people in asylums and institutions, but it really didn't do any good because we really didn't know what we were doing for the most part. And so a lot of the traditional therapies that were being done really weren't very helpful, aside from, keeping them in one location, which really didn't do any good. So within the 1950s, we started to develop some medications which allowed for more outpatient therapy, and specifically what we call milieu therapies and token economies, which were we use these today, are therapies that are very humane and look at the person as a whole, not just as somebody who's sick, somebody who we can really help through some social skills, through helping them with community skills, teaching them how to get a job and understanding their disorder. And along with that, it's making sure they understand the importance of taking their medication on a daily basis. Antipsychotic medication is the drug category that tends to be used for psychosis when we're talking about schizophrenia. And it was about the 1950s that a lot of these antipsychotics were developed. And it was a really kind of serendipitous thing because sometimes they were developed for other disorders completely different, tuberculosis, other kind of biological problems. But they found that this could also help with some of the delusions and hallucinations that people with schizophrenia were also experiencing. So some of these kind of typical drugs would cause some neurological problems. So they developed what we call atypical antipsychotic medication, which tends to work for a good 65% of people. There are some problems with certain medication. It depends, what kind we're talking about, but some of the conventional antipsychotics that we used before the modern day medications used to cause a lot of different neurological kind of problems, some Parkinsonian type of symptoms, again, if they take too much. There was something called tardive dyskinesia, which is this, again, there are these kind of tics. It looks a little bit like Tourette syndrome, some sticking out of the tongue, some strange kind of mouth movements. They say that about 10% of people who are taking some of the conventional antipsychotics would develop tardive dyskinesia. And you even see some people who are dealing with it today. And there's other medications out now that even deal with this very specifically. If you need to take a very specific kind of antipsychotic medication for your specific needs, and tardive dyskinesia tends to be a side effect, they now have medication actually to help with this. And some of the conventional also, you have to be really careful. You can't stop it too abruptly. You have to make sure you're weaned off of it, because if you stop too abruptly, sometimes the psychotic symptoms can come back worse than they were before. So the newer, what we call kind of atypical, the newer antipsychotic medications, you might be aware of some of these names: Clozaril, Risperdal, Seroquel, Abilify. Some of those are much more common as far as some of the names. These new atypical tend to be less likely to cause tardive dyskinesia and some of the other kind of Parkinsonian kind of symptoms that we see with some of those older medications. Psychotherapy, again, can also be very helpful. We call this adjunctive therapy. So, of course, medication is incredibly important for helping with this psychosis. By the way, some of the antipsychotic medication can also make people very sleepy and very tired, which sometimes contributes to some of the lack of motivation you see when people are in their active stage, but sometimes that can't be helped either. So having adjunctive therapy, meaning therapy in addition to medication, is very important for schizophrenia. It's important for the person individually, and if they're living with a family or a group or they're married, that's also important therapy to have, because we want everybody involved to understand what the schizophrenic is going through, somebody with schizophrenia is dealing with. We might want to help, in a social cultural way, how you might be able to deal with people who are in these kind of active phases. And when they're going through their periods of normalcy, how you can help them get a job and hold a job and hold a relationship, and really help them be a member of society and be happy and healthy and have a normal life as much as possible during those times when they're not in those active phases. The typical kind of therapy we tend to give is cognitive behavioral. CBT therapy works with everything. CBT is a wonderful type of therapy which involves cognitive. When you hear the word cognition or cognitive, think about thinking. So you're changing your thinking and you're changing your behavior. Best combination for almost anything you're dealing with. So it's helping people rethink through what it means to have schizophrenia, and to think maybe about their hallucinations in a more practical way and be able to label them as, these are hallucinations I'm having, they're not real, the voices in my head are not real, and to not listen to them, and just interpret their hallucinations and even their delusions in a more realistic way. Family therapy, incredibly important. Family stress in any family, but especially if someone has any sort of psychological disorder, has any kind of mental illness. So helping everybody in the family through that is so important. Again, social therapy will really help a person stay out of an inpatient program if they can learn to deal with their medication regimen, be able to be maybe financially assisted to the point where maybe they could become financially independent and live on their own, or have a family of their own. That will help them become more active members of society, and then maybe some outpatient therapy is all that would be needed. Unfortunately, we see about a third of people who are homeless in America have some sort of mental disorder, and usually more often than not, unfortunately, it is schizophrenia. So we really do need a stronger community approach, and we're kind of actively working towards that here in the U.S. and abroad. So schizophrenia is a very complicated issue, without a doubt, and it's not just about the person who's affected. We really need to look at this in a global way, not just somebody who may be married to someone who's experiencing these symptoms, or in a family or a friend, or, within a work situation. Even within a community and within the U.S., we need to figure out what is the best, most humane approach to dealing with people who are struggling with mental illness. So this is something that is an ongoing difficulty, but also ongoing research that looks really promising. I'm very optimistic about where we're headed in this direction when it comes to treating mental illness. We're not there yet, but I feel optimistic about the future. Hope you have a wonderful day. If you have any questions about anything that was talked about within the video, feel free to ask me at any time, and I can clarify any issues that you might have. Have a wonderful night.